What's going on, everyone? Welcome back to another episode of the Core Consults RX podcast. And tonight we're not doing an accredited episode. Cole and I were just chit-chatting before we started recording that this is the first time we haven't, had to do more preparation. And
it's been a couple months.
Yeah, I feel like this is a lot less pressure.
So if you thought that the accredited episodes
if you thought
the
prepared material was bad, wait till you see the improv. Yeah, for sure. But at least they can't get too mad if we go off on tangents tonight,
right?
So
right.
How's
they're
life,
not
man?
sitting there waiting for the password. It's good.
Yeah,
it's good. Yeah,
for the passwords. It's true. No password this episode.
Right. Oh, that's true. We don't have to remember that this time.
Yeah.
What about you?
Pretty good, man. Same old. Just I got 1 week left of actual lecture, and then their final exams, and it's a whole nother PA group cohort. It's gotten through didactic already. It's crazy.
They ended this time of the year?
Mm-hmm. Well, they start right into some other stuff, but they're done with my the block that my class is in. They're done with.
I see.
So yeah, I don't think they really get much of a break from here on out, because then they start clinicals. I think in January maybe. Yeah,
the PA curriculum is compressed.
It is tough, because I think people assume, it's a 2-year program, so that'll be a better, easier way to going than going to get a doctorate. It's a shorter way for sure.
Yeah,
but it
fit a lot of info into those 2.5 years.
It is a brutal program.
Goes through summers.
Yeah,
it's really like 2 years and 3 months.
Yeah,
right.
And it's intense. It's not like getting a master's degree in whatever.
I mean, in hindsight, though, I at the time really wanted the summers off that I had. I would have rather just choked through and got it done faster,
Yeah, you say that in hindsight because you're done.
Yes.
Yeah.
In the moment, it would have been horrible.
If you went back right now, I feel like you'd still be like, you know what, summers are pretty dope. I'm going to go ahead and keep doing summer thing.
But my hope would be if it's shorter, it's cheaper.
Yeah, that's true.
And which might not be. But then, of course, you start earning earlier and stuff like that.
Yeah, it's good. Opportunity cost. There you go. Yeah, this is now an economics podcast. Gosh, we would lose everyone. Or maybe you, but if I was giving economic advice, it'd be...
Wasn't there like a farm economics podcast?
I don't know. Maybe.
Didn't they record out of your studio for a second?
Oh, yeah, duh. Yes, they did start that one. I don't think they ever... They did 5 or 6 episodes from what I saw, and I haven't heard anything from them in a while.
Okay, yeah.
At least they're not recording with me, so I don't know.
Yeah.
But yeah, no, they did.
Yeah, that would be really boring if we did it.
Yeah, we don't know anything.
Well, it might be very interesting, because a lot of people would lose a lot of money.
Well, people would be like, well, I guess we know what not to do.
Right.
These two idiots.
So here's what we've done since graduation.
Yeah.
Do the opposite.
Yeah, exactly. Buy tons of cars you don't need. They depreciate immediately.
Have an Amazon package come every day.
Oh, at least.
If you go a day without an Amazon package, that's a problem.
You didn't do it right.
If you're not on a first name basis with your Amazon driver.
Right. Yeah, absolutely. That's where we're at right now. No, but since we're not doing an accredited episode, we wanted to kind of just touch on a new drug that came out fairly recently. It is a new antidepressant. Cole, had you seen this or heard much about this before it got approved?
Not a thing.
Yeah, I hadn't either, because it's one that they've actually been trying to approve for quite a while. The name is gepirone. Gepirone, I guess is how you pronounce that.
Sounds good to me.
And the brand name is Exxua. It's EXXUA, and it's an extended release capsule that is for the treatment of major depressive disorder in adults.
It's from Faber-Kramer Pharmaceuticals.
Yes.
I've heard of them. Approved last month, September 28th.
Yeah, and it's kind of a unique class of medication. I guess they're saying first approved, first in class kind of thing, but it's basically an agonist for serotonin 1A receptors. So it's not like an SSRI necessarily, or it doesn't have that blockade of the serotonin reuptake. It is actually going after that one specific receptor. So 5-HT, which is just serotonin, 5-HT1A agonist. Right. And we've kind of seen this idea with things like Trintellix, because the idea with Trintellix is, it has the standard SSRI, component to it, the mechanism. But with a normal SSRI, you get that initial, that synaptic cleft increased concentration of serotonin, which that's going to allow for more binding to 5-HT1A specifically, which once that interacts with enough serotonin, you get this negative feedback where it kind of shuts off that serotonin signaling, and you have to overcome that downregulation of 5-HT1A, which is why SSRIs take like 4 to 6 weeks or so to really start working, at least 2 weeks to start seeing any effects, because you have to overcome that downregulation of 5-HT1A. So with Trintellix, they have, and vilazodone is the other one. Basically, they took a regular SSRI and then added that activity with 5-HT1A partial agonism or agonism to sort of start the process of overcoming that downregulation of the serotonin signaling from the start, so that it ends up working a lot quicker than a standard SSRI alone.
Yeah.
But you have all the side effects of a normal SSRI, maybe a little bit better from like a sexual dysfunction standpoint and whatnot. So with this drug, they kind of just went ahead and got rid of the SSRI component and just went with the 5-HT1A agonist activity. So it's a standalone drug that is unique to going after that specific receptor.
Right. And you can think of some other drugs that target those specific serotonin receptors, like triptans target 5-HT1B and 1D. There's a couple other migraine medications that target 1D. Of course, this is 1A, and I think what's notable, so there's a couple of studies that got it approved there that were used to get it approved. They're interestingly somewhat small. There was about 120 patients in each arm of both the studies. They only went for 2 weeks, and they were looking at a statistically significant decrease in the HAM-D scores versus placebo. Which we've talked about, the HAM-D and other types of depression rating scales. It's just some sort of somewhat objective measure of somebody's change in their depressive symptoms, positively or negatively. So over the 8 weeks, they saw about a decrease of 3 more points on the HAM-D score with the medication versus placebo. Which, what does that mean? Well, they determined that it resulted in a statistically significant decrease in their score, which improved their depressive symptoms. Only 8 weeks, which I guess lends credence to the
how quick
speed, because I don't know offhand, but I feel confident that studies with SSRIs would run more like 2 to 3 months at minimum. You know what I mean?
Yeah.
Or I'd say 3, where this is 2.
Well, and the other thing was the patients that they were looking at, like the maintenance study, that they were looking to see who, the patients who had initially responded during that open label treatment were then randomized to continue the drug for up to 12 months or to switch to placebo. And then the patients, they were looked at to see who had a relapse of of their symptoms during that period. Right. So I think that was kind of like the follow up to it.
Yes.
But in that particular case, 24% of patients ended up having a relapse that were in the treatment group who continued treatment, and then 38.7% in the placebo group. So basically patients who came off the drug after that initial 8 weeks.
Yeah.
So
that seems to fit with other things.
Yeah. That definitely supports, obviously, maybe continuing it for that year. But right. I still say, even though coming off of it after only 8 weeks of therapy, 38.7% were who relapsed. It's still quite a big percentage of patients who didn't relapse.
Right. Was that placebo or was that treatment?
No, that's so when they were the patients who in the treatment group, who had responded to the drug, then were randomized to continue the drug or switch to placebo. I see. Yeah. So they were all initial responders.
Interesting.
Yeah.
The side effects, some of them are what you would expect. Some of them aren't, kind of like Mike had referenced. So most common side effect was headache, or actually the most common side effect was dizziness and nausea. Dizziness occurred in about half of patients, nausea in 35%. Then headache, tiredness, insomnia, diarrhea. But going down the list, what was most notable to me is that there were no sexual side effects mentioned, which Mike mentioned why. But that's very significant.
Yeah.
Very significant.
I feel like that's one of the biggest reasons why people are coming off of SSRIs or can't tolerate them, at least in younger patients. So, yeah, that's a huge win.
We have Wellbutrin.
Bupropion is usually,
And then maybe Boost Bar is not going to be very significant with sexual side effects or something like that.
right, which
Most
is
of the
actually
others-
very similar to this. I mean, technically speaking, they're in the same class as Buspar. This one has I think the difference is Buspar has a lot more affinity towards the I think it's D2,
Gotcha.
one of the dopamine receptors as well, whereas this is specifically towards 5-HT1A without the dopamine interaction.
Right.
So there would be technically maybe even like less of a stimulant effect, although that is still listed as a side effect, like things like insomnia and whatnot. But,
which insomnia is still a concern with this.
Yeah, that's what I'm saying, yeah.
With the dosing, kind of unusual numbers, which some of them are that way. I guess that's just, I wonder if that comes out of like rat studies where they come up with these very
Where
specific
it's
milligrams.
18.2,
So
yeah.
it's 18.2 milligrams. Like Mike said, it's an extended release capsule.
Tablet. I said it wrong earlier.
Extended release tablet. Then it can go up to 36.3 milligrams, 54.5, and 72.6, and it's once a day. As far as how they recommend increasing, on day 4, they say you can go on up to 36.3. Day 7, 54.5, and then 72.6 once a day after an additional week. So compared to other major depression medications, that is a quick titration.
Yeah.
I mean, it's quick.
Which, I mean, the study only went 8 weeks, so you kind of have to expect a quick titration.
Right.
But I think that's because of all the lack of side effects from, you don't have to worry about in this case. I mean, you're still side effects, but you know what I mean? Not the SSRI side effects.
And I mean, another big reason for discontinuation, at least one of those counseling points that like a pharmacist is told to harp on, is to give it time. It's going to take time. You're going to have to get past these transient side effects that are going to occur. And I'm sure there are people who stop or switch in that interim period before they would get to the,
Actually feeling
better.
Yeah.
And yeah, I think that this could be beneficial there. So, I mean, do you think it's taking the place of anything?
No, I mean, not necessarily. To me, it would be one of those situations where, maybe they've tried Wellbutrin, it didn't work, and, they can't tolerate the side effects of an SSRI, SNRI. That's kind of the patient that I would think maybe it would fit for. I don't know that I would say first line or anything like that, at least until I know more about it, I guess. But from what I've seen, I don't know that it would necessarily replace an SSRI or anything like that. I mean, maybe.
We'd have to see it compared to something, which probably won't happen.
Be interesting, but I don't know that that's ever going to happen.
No.
The one thing to be aware of, though, is it is a major substrate of 3A4. So you didn't talk about this already, did you? Okay. So if the patient is on another like moderate 3A4 inhibitor, then you have to reduce the gepirone dose by 50%. And then if it's a strong 3A4 inhibitor, completely contraindicated, don't give at the same time. So that's one thing to keep in mind. And then Cole had you mentioned the QT prolongation already. Did you go into detail about that,
No,
Cole?
not at all.
So this is the part that I feel like would be the most problematic for me, I think, as far as getting patients on it. So some things to consider, typical, medication that's going to affect serotonin. We want to make sure that we're screening for like bipolar disorder, any history of mania, hypomania, anything like that. And then, we also want to get a EKG on the patient at baseline, because this medication can prolong the QT interval. And it's actually one of those things where the patient is at baseline, their QTC is greater than 450 milliseconds, then they can't even start this medication. And so you have to do an EKG at baseline, and then you're technically speaking, you're supposed to also do an EKG before dose titration and then periodically during treatment. You also have to correct any like electrolyte abnormalities that may be occurring due to them being on steroids or diuretics or whatever it may be. And if there are electrolytes, and also not forgetting to check magnesium as well. If there are electrolyte abnormalities, you have to correct that before starting it as well, so you don't increase the risk of that QTC prolongation and eventually developing torsades.
Yeah, I can tell you just from experience with some providers who maybe were treating elderly patients and were more concerned with QT prolongation with other medications like, Seroquel or something like that. It is definitely something that impedes starting medication, or will definitely deter them, or I would say deter them if that's the extra step that you have to go through. It's not a huge deal. I mean, a lot of times it can be done in the office the same day, stuff like that, but it's just an extra step that you wouldn't have to worry about with other things. We were chatting that citalopram has a concern, but they don't even recommend a baseline EKG unless somebody has risk factors or something like that.
And I mean, obviously, if they do have risk factors, if they're over the age of 50, then sometimes they will. But I mean, how often is that really done? So that's what I'm kind of wondering is once this actually hits the market,
how often will it be done?
Is it something that people are actually going to follow? And I feel like the warnings are a lot more specific on this. So I'm thinking the risk is probably a lot higher with this compared to, or at least the theoretical risk is higher with this.
I would agree. I wonder what they saw in terms of how much they saw increases.
And that's the part. I didn't really dig into that part either. I just, blurred through some of the warnings and things. So it'd be interesting to see, why that got put on there. So if anybody comes up with that, let's send us an email and let us know so we don't have to do the research.
It does have renal and hepatic dose adjustments. So 50 milliliters per minute, GFR 50 is kind of the cutoff. Less than 50, start at the 18.2 milligrams per day. You can increase to a max of 36.3 after day 7. So effectively half the regular max dose. Same with hepatic impairment. If they have a child puke score of B, then you would follow those same instructions. And if it's severe child puke C, it's contraindicated. Similarly, in older patients, geriatric patients over 65, kind of follow those same guidelines, maximum 36.3 milligrams.
Also, so as far as pregnancy safety, we have no safety data in humans as far as pregnancy risk or concerns there. But in animal studies, there's actually been shown to have some adverse effects from embryo fetal postnatal development. So at least in rat studies. So it's something that if you have a patient who is thinking about becoming pregnant or becomes pregnant, definitely want to probably switch to something else until we know for sure that this doesn't actually lead to harm.
I wonder if it would be helpful with anxiety, kind of like Wellbutrin is. I mean,
so
it's a totally different mechanism.
What I understand, they're looking at it for, there's a study right now. Let me see if I can find this while we're talking. There was a study going on right now for one for anxiety, and then one was like for weight or something. Shoot, where was that? But yeah, there is basically, because it's a similar mechanism to buspirone without the dopamine activity, they are looking at it for an anxiety, which makes sense because 5-HT1A as well as 5-HT2A plays a role in anxiety and all that. So
right.
So what was that? Something just fell off Cole's microphone. That was pretty funny.
I have no idea.
I got totally distracted. I was like, what was that?
I think that it's notable that it doesn't have any weight gain associated with it. Another issue with SSRIs. I won't say any, but I'm looking through the adverse effects.
No, I think it's actually.
I don't see anything.
I think weight loss is something that they're actually considering it.
Interesting. Yeah, I see like a 3% mentioned weight increased, but at least it's for sure not significant. Two biggest complaints. Weight and sexual side effects with SSRIs.
Yeah.
They got that figured out.
It'll be interesting. And I'm wondering cost too, because I didn't see anything on cost, did you?
No.
So I can't imagine this is going to be sertraline cheap.
Oh, no.
So
probably
hopefully
$600 to $1,000.
Yeah, I hope not.
Yeah.
But yeah, so I'm not going to sit here and search for it, but there are ongoing trials with this medication. So take a look at those if you're interested, and I'll try to find them later.
They do say you need to take it with food.
Yes.
The absorption is relatively fast. With a high-fat meal, the peak plasma time is reached at 3 hours. It's about 14 to 17% bioavailable, and it reaches steady state at 2 to 4 days. The peak plasma concentration after the intake of a low-fat meal, which they consider about 200 calories, like breakfast, was 27% higher. After a medium-fat meal, 55% higher, and then the high-fat meal, 62% higher. So they definitely recommend taking it with food.
Yeah. Anything else with this that you saw?
Half-life of 5 hours.
Yeah, this is a short half-life for being once a day.
I mean,
I guess
steady
just
state of 2 to 4 days. Yeah, an extended release tablet with a half-life of 5 hours.
It's pretty, it's weird.
Yeah. Well, I guess that's why it's extended release, because the drug itself is half-life of 5 hours.
Yeah.
Interesting.
Yeah, pretty cool. I'm glad. I mean, it's just good that we're at least getting something new. While I was looking at some of this stuff, there's also a ton like in the pipeline for schizophrenia medications being targeted for different, even like first in class. You know, we've went over some of that in one episode. I can't remember a while back.
Sounds familiar.
But yeah, there's some cool stuff coming out for behavioral health meds. I'm pretty excited. We'll keep you guys up in the loop as we go, as we read about it.
Yeah, you don't get new stuff for major depression too often.
No, especially not a first in class.
No, it's been a few years since that Trintellix.
Well, what's the newest one? The newest one was that bupropion and dextromethorphan combo.
Oh yes.
I can't remember. It starts with an A, I think.
Yes.
It's like I don't even remember. Yeah.
Which is really just a combination of something.
It's basically just to enhance the effects of bupropion and maybe provide a little bit of an extra. Benefit.
Yes, new drug,
different
first
mechanism.
in class. Interesting.
Yeah.
Interesting.
Pretty cool.
Heard it here first, maybe.
Well, we're a little late to the party on this one. It was like 2 weeks ago, so probably didn't hear it here first, but that's okay. But yes, so thank you guys so much. You know, if there's any topics or anything you guys want us to cover, we're definitely always willing to take requests. We don't know if we'll actually do them or not, especially if it's something that's way out of our wheelhouse. But if you guys have any topics or anything, we'd definitely like to hear what you guys want to hear, what you want to hear about. And definitely check out pearls.com, pearls, pyrls.com/coreconsultrx. And it's a great drug app, you know, for drug info resource and really good pharmacotherapy algorithms and flow charts and all that good stuff for those of you who are visual learners. It's a good tool. And also check out the Patreon. It's where you can get all of the more traditional style lecture, PowerPoint slide, and all that good stuff. And, you know, just goes through various disease states and pharmacotherapy topics and whatnot. And it's probably the cheapest pharmacology review you can do, and it helps support us in making sure the show is good for you guys. So we appreciate all of you who have checked that out. And also, if you have any questions for Cole or myself, make sure you send us an email. You can text message us directly, send us a message through, you know, social media, whatever you prefer, and we will do our best to get back in touch with you. And we appreciate all of you, as always, for continuing to listen to us. We'll catch you guys in the next one. Have a good night.